All right, we're talking about disparities today.
What is that?
We'll find out. There we are. Why don't you read it since you asked what it was?
Health disparities, significant gaps or differences in the overall rate of the disease and disease prevalence, how you say that word?
Morbidity.
Morbidity, mortality, or survival rates in the population as compared to the health status of the general population. Many definitions sometimes subject to.
Does that make sense to everybody? Because it was a long definition.
Is that like a
Can you summarize
socioeconomic
that
gap?
for me?
Similar, but in relation to healthcare.
In relation to
So, a health disparity may be, we can think about Native Americans and how, let's just say, for example, I don't know what the percentages are, but let's say Native Americans have a high percentage of diabetes. That might be a health disparity. If their percentage of diabetes is much higher than the overall percentage or average of all other populations, that would be a healthcare disparity. So basically a disparity is, like I said, a significant difference in a disease incidence, which could be diabetes, high blood pressure, heart disease, cancer, et cetera, et cetera. So, do we all know what it means now? Cultural proficiency relates to healthcare disparities because it deals with a person or an organization and their ability to respond to different types of people. So if I'm working in a hospital and you come into my hospital, but you only speak German, my ability to react to that and to assist you and to help you is going to determine my cultural proficiency. If I don't know what to do and I turn you away and I say bye, my cultural proficiency is bad, it's low. If I accept you and bring you in and I have a service that I use, that's a translator service, my cultural proficiency is high. That means my willingness and my ability to respond to you because you're different, because you speak a different language is good, then my proficiency is high. And so again, cultural proficiency relates to disparities because if we have a certain race or a certain religion, if we think about Jehovah's Witnesses who don't tolerate all types of procedures, if we have a policy in place to accept that and respond to it, then we as an organization or we as individuals are culturally proficient. Or in other ways that you might see this is cultural competence, cultural sensitivity, cultural conditioning. They all pretty much mean the same thing. So, it's funny, huh? I just used this example. Here's an example. Diabetes. The Pima Indians of the Gila River Indian community, which is near Phoenix, Arizona, have highest rates of diabetes in the world.
I thought it would be African American.
That's what we hear.
Yeah.
I wonder why.
And Hispanic.
We'll talk about that a little bit later if we have time. Hispanics, African Americans, some Asian Americans, Native Hawaiians, Pacific Islanders, including Japanese Americans and Samoans are also at risk for developing type 2 diabetes. A lot of this just relates to lifestyle, things we eat, the exercise we get or we don't get. It's just, like a lot of it is just lifestyle, access to care. If we're not regular getting checkups to even know that we have diabetes, how can we treat it? Again, we'll get into that a little bit later, into more detail. Here's another example, infant mortality. Does everybody know what that is? Infant, baby, deaths of babies. even when we control for socioeconomic factors, which are based on basically what you make, your status, poverty level, etc., the rate of infant mortality has been twice as high among African Americans as compared to Caucasian Americans during the last decade. So this would be considered a disparity because it's a significant difference. Infants of Native American and Alaskan descendants have also had a death rate almost double that of Caucasian Americans. So again, another example of disparity. Heart disease and stroke, higher in African American population than Caucasian Americans, another disparity. So going through those examples was important because I wanted you guys to clearly be able to understand what disparity means. As healthcare managers, that will be important for you to understand because it's going to determine how you look at your case mix or the people who come into your hospitals and how to treat them and how to provide the correct preventative care for them, again, so they can get those tests to see if they have diabetes or heart disease. Now Allison asked a good question. Why is that? Why do we have disparities? Here are some of the reasons. I told you we can come back to it. Access to health insurance. Everybody doesn't have insurance. You don't have insurance, you're less likely to go to the doctor regularly to get checked. Some of it's genetics. If you have a lineage or a family that has history of diabetes, breast cancer, whatever it may be, there's a possibility that you also may get it. Socioeconomic factors. Maybe you can't afford to go to the doctor. It's just not in your budget. Maybe you have to choose between getting milk or filling your prescription. And that happens. Living and working conditions. If you are working in a factory where you have hard labor every day, you're being exposed to chemicals or smoke or something that's harmful to your body. And if this is the only, if this is the big factory in town and there's nowhere else you can really work in that town because you live in a small area, it might affect your conditions as well as your family if everybody in your family works there. And some towns are like that. Beliefs. I touched on this a little bit with religion, with Jehovah's Witnesses, Catholics, and there's other religions as well that just don't believe in certain procedures. If that's the case, it may prevent them from having that surgery to remove the tumor or whatever it may be, having that blood transfusion. And last, the patient's adherence to preventive and therapeutic measures. I personally, speak with guys who don't enjoy going to the doctor necessarily as women do. So there's probably, for certain things, a disparity in male and female because they don't like going to the doctor to get the preventive care. This is a diagram that shows you how the demographics is changing. Can everybody understand this? It's color-coded over here. So this is other Asian, Hispanic, African American, Caucasian. This is 08. This is 2050, how it's expected to be. So you can see that Asian is expected to double almost. Hispanic is expected to double. African American expected to stay about the same, increase by 1%. And Caucasian is expected to decrease by 20%. While you may look at this diagram and say, all right, Dr. Haynes, it's a diagram. But if you think about everything we just talked about and all of the disparities and the fact that most of the disparities were involving minorities, okay, let's put those two together. Most of the disparities involve minorities. We look at this diagram, all the minority groups are growing, which is going to mean what? It's possible those disparities are going to increase even more. And so now that we've put all those pieces together to figure that out, now it's an issue. Now we see why this diagram is important to us as managers, because these are the people more than likely that we are going to see in our ED. If they're not going to the doctor regularly, these are the ones that are going to show up with the stroke at the ED, show up with the heart attack, which, as we know, are more expensive than just allowing them to get that preventative care. Any questions about that? That one. Hopefully this diagram put everything together. So, how can we as managers and as an organization respond and become more culturally proficient? Well, here are a few things. We need to have diversity in our workforce. We need to have a workforce that can respond to this patient that only speaks German, or Spanish, or Creole, or whatever it may be. Now, in order to have that, we gotta have a supportive group of leaders, right? And a supportive organizational culture. That means we have to have a group of leaders and a leadership team that's accepting of having a diverse workforce and understands the reason why we need to hire people that are multilingual or bilingual or whatever it may be. We need to have appropriate human resource policies. What that means is, within our human resource department, we need to have policies in place for when events happen, such as someone coming in, speaking a language that we are unsure of how to understand them. Assessment. We need to, measure ourselves to see if we as an organization are culturally proficient. There's a few different ways we can do an assessment, but just knowing that we need to do it for now is important. We gotta be trained. How do we get training? Well, there's seminars. You can send certain staff members off to workshops to come back to the organization and bring that info. You can have mandatory training, whatever it may be. A lot of organizations now have diversity training. And at some point, especially if you're in management, when I worked in the hospital, I had to go through diversity training. So in most organizations, when you get to the management level, you'll be required to do some type of diversity or cultural education and training. We just talked about multilingual services, especially in Florida now. A lot of hospitals have translation services where they will, they pay a monthly fee to be able to call a 1-800 number or something if they have a patient that comes in and cannot speak the language that they know, which works well. Some organizations have specifically hired people just to translate. That's their only job all day, is they go from patient room to patient room or registration all around the hospital to translate. Evaluation and research. So, as we should know by now that as managers, we never stop researching. So, that's another way to make sure that we've become proficient. Community outreach and engagement. The more that we're seen in the community, the more comfortable the community is going to feel with being accepted. So if we go, if we were thinking in terms of that one example that provided of the Native American tribe in Phoenix, maybe as a hospital we should go out to that reservation and provide a health fair or do blood pressure checks. Those are the types of community outreach events that will show the community that we are trying to be culturally proficient. And public policies. Some organizations have policies that were written in the early to mid 1900s. They probably need to be updated, revised, changed, deleted to reflect the population now that we have, which we just saw. We need to make sure that our policies reflect this and reflect where it's going. So, here's an example of a few standards that have been developed by a class which is culturally and linguistically appropriate services. The first standard says that healthcare organizations should be able to ensure that patients receive effective and understandable care that's provided to them. What that means is, if I'm sick and I'm in the hospital and I'm Haitian and I speak Creole, this hospital should be able to provide some type of way, nursing care and physician care, that they can relay to me, that I can understand what they're doing. So if I'm getting an IV in my arm, some type of way this hospital needs to be able to relay that information, that I'm getting an IV in my arm and I'm getting it because XYZ. That's standard one. Standard two deals with staff. The healthcare organization should be able to create strategy to recruit and train and promote staff members at all levels of the organization that represent the demographics of the area they serve. What that means is, if I live in Miami and my staff, no one on my staff speaks Spanish, am I adhering to standard two? Not at all, because my staff does not represent the demographic area that I'm serving. So what that means is, if I'm living in Miami, if my hospital's in Miami, I need to make sure that my organization has recruited, retained, and promoting staff that represent my area. So I should have, and if I'm in Miami, I should probably have staff that speak Spanish, Creole, and who knows whatever else, patois, whatever, in that area. So that's standard two. Standard three says that healthcare organizations should ensure that staff at all levels and across all disciplines receive continuing education as it relates to diversity and being culturally proficient. What that means is, just because you receive that training and orientation when you get hired, you probably should be receiving more training on diversity every year or so. It shouldn't be 5 years that go by before you receive diversity training again. Standard three. Standard four says that healthcare organizations must offer and provide language assistance services at no cost to the patient, right? So just because, we'll go back to our German example, just because you come in and you don't speak German, and I say, that's okay, we have a translator service for $5.95. That should not be the case. It should be provided to the patient at no cost. That's the hospital should take on that cost to provide that. Standard five, healthcare organizations must provide to patients and consumers in their preferred language verbal and written notices informing them of their rights to receive language assistance services. What that means is, if we have someone that can speak Spanish and English, if it's obviously clear that their primary language is Spanish, we can't be trying to explain things to them in English just because we speak English when we know that English is not their strong language. So what are the benefits? We know it's gonna cost money, right? So we have to see, is it worth it? What are the benefits of being culturally proficient? Well, number one, it's good business practice. As a business, you should want to provide this to your patients. It's going to improve your satisfaction, obviously, for your patients, for your customers. It's probably going to increase your market share. If you're able to reach out to different populations, then more than likely, once they know that they can come to your hospital and have translator services, they're probably going to tell other people, oh, you can go to that hospital where they have someone there that speaks Spanish. So it's more than likely going to increase your market share. It's going to decrease malpractice claims, because if you're speaking to people in their primary language, there'll be less errors, less assumptions, less, oh, I thought she said this, but she said that. types of situations. And obviously, if you're increasing your market share, that money you spend on that translator service, you'll get it back because you'll have more patients coming to your hospital. And you're gonna have a good workforce management. You'll have decreased turnover. You'll enrich the future talent pool. What that means is if you look beyond your current staff and you look out and you try to reach out to staff members that are bilingual, you're obviously going to have a more diverse staff, a more talented staff. Decrease lawsuits. And last, ethically, it's just the right thing to do. If you're becoming more culturally proficient as an organization, you are showing that you have moral standards and you're being ethical. Have another diagram. I have a lot of diagrams for you today. Have another diagram. This is the hospital. On this side, over here we have government agencies. Here on this side of the hospital, we have a diverse healthcare workforce, leadership, assessment, we have cultural proficiency training, multilingual services, community outreach, etc. On the government side, we have public policies, education, research, and investment. And in the middle, we have happy family dancing around in a circle, singing Kumbaya. Now, this is the community. So basically what this is saying is that, you know, organizations have to work with the government agencies to be able to address the healthcare disparities. And the way they do that is by becoming more culturally proficient. Questions about that diagram? Questions? All right. So, to wrap up what we've talked about, again, we have huge disparities in this country. Most of them are going to be found in the underserved populations. This is important to know because, again, as we looked at that diagram and saw how the groups of minorities are going to grow, again, the burden of illnesses is only going to get worse. Heart disease is going to go up, stroke is going to go up, diabetes is going to go up as the U.S. population becomes more diverse. So, as managers and leaders of healthcare organizations, we have to make sure that we can support that community by being culturally proficient. So what that means is once we get into a community working at a certain healthcare organization and we realize, wow, we're getting a lot of Spanish patients coming in, we need to do something about that instead of just noticing it but not doing anything. So even if we aren't in a position as managers to make decisions, this is still information we need to take to our manager and say, I'm noticing there's a lot of Hispanics coming in. What can we do? Can we start a translator service or something to help us provide them with good care? And again, like I said, when I worked in South Florida, I saw a lot of that with the translator services and us being able to help populations that spoke different languages. It was a good feeling to be able to help them, because the last thing you want to see is someone in a lot of pain and you have no idea what they're saying and it makes you feel helpless when you can't speak with them to try to figure out how to help them. So being able to have those types of resources definitely is a big help to the community. Any other questions about disparities? I hope you guys are taking notes today, because if you've looked at your next project,
Yeah.
it talks about this, right?
It did.
Talk about it.